Mr Chairman, ladies and gentlemen of the committee, can I, on behalf of the Alcohol Forum, just express our extreme gratitude at being invited to speak today. Whilst our written submission on this theme was very much focused on the relationship between alcohol and cancer, we're more than clear that our peers and colleagues in other organisations have addressed that issue quite consistently today. But we're delighted instead to be asked to speak very specifically about the models and processes that we follow to try and change lifestyle behaviours in the northwest of Ireland. In doing so, I want to outline just some context on the Alcohol Forum first. The Forum as a charity has been around for almost 10 years now, and it grew organically from a series of conversations more than anything else from key people in the community who started to realise the impact that alcohol was having in the broader health of the community. And those informants were in all walks of life, be it health service, Gardaí, education and in community. And what they really saw was the need for a collective action to change the culture of alcohol consumption, and from that the Forum developed itself with a range of interests in the public sector to develop a primary concern about how do we change lifestyle behaviours in relation to alcohol consumption with a view to protecting current and future generations. I should say that we're not an anti-alcohol organisation, but what we are interested in is achieving a balanced consumption of alcohol in our society. And whilst our work has tended to be confined to the northwest and the border corridor, it is our intent to franchise the learning of our work across the region and across the country in due course. We're very focused on how the learning that we've developed will influence and support the development of the substance use strategy as it rolls out as government policy. We've also been very fortunate that our work has been supported by successive governments, and indeed in 2005 the Minister for Health designated the Northwest as an area of special interest in addressing alcohol-related harm, and that gave us real impetus to see how we could mobilise communities to address actions for change. The actual model we've used is defined academically as community mobilisation. It is recognised by the World Health Organization as a key vehicle through which to change lifestyle behaviours, and is currently being longitudinally evaluated by Dr. Harold Holder of the University of California. What the mobilisation model seeks to do, and I think where it's relevant in relation to your debate on lifestyle change, is it seeks to build a comprehensive response to an issue that's too big for one sector on its own to tackle. We use that vehicle very specifically in relation to alcohol, but our experience has shown that that vehicle could also be used to address issues such as smoking, obesity, diet, nutrition. It is a way of getting people engaged in developing new ways of working. In the early days of our work, however, we became I suppose, very interested and very aware of some public health developments that were happening with our near neighbours in Derry. Derry City was designated as a World Health Organization Healthy City in 2009, and the Derry Healthy Cities project has been leading on public health engagement in the northwest of Ireland for over 20 years. It is very much at the centre of building the economic and social regeneration of Derry. And for us, because of our very close alliances, not only just in terms of geography, but also in terms of communities, we saw that the methodologies that they were using in terms of improving public health were things that were very relevant to our work in changing lifestyle change. The key things I want to focus on, though, that in relation to their work that we've adopted are addressed in a number of key points. Firstly, the work that they undertook in relation to changing public behaviours, to changing lifestyle, focused very much on the realisation that health is too important for the health sector alone. They very much underpinned the idea that others had a role to play in this piece of work. The second thing that was key was that they had strong endorsement from the Northern Ireland Public Health Strategy. Evidence and experience would show that any behaviour change, any attempt at behaviour change will flounder if it's not underpinned by national policy. We were very taken by their settings approach to health improvement. They identified where people were at. For example, and you've heard about workplaces, we spend about a third of our waking life at work. We're better, therefore, to talk to people about key messages in relation to lifestyle and behaviour change. There was very much a similarity in our populations. In fact, health and health deprivation across the island of Ireland is no respecter of borders, and for that reason there was a real synergy in us working together. And finally, they recognised that by setting processes for change primarily in the community and voluntary sector with public sector support enabled a flexibility and a dynamism that sometimes is restricted when it's placed within other sectors. And I suppose most importantly and interestingly for us, working in Donegal, Sligo, Leitrim, was the idea that local government took a lead to provide some form of civic leadership to enable the interagency and intersectoral working that had to happen to allow lifestyle change to move forward. And what was core to their overall approach was this idea that The progress could only happen through a process of building capacity. If we don't build our citizens' capacity to understand the messages that we're trying to get across to them, we will not affect lifestyle change. In our own work in mobilising communities, we recognised very quickly that those communities who progressed most slowly in change were those that didn't have some form of earlier intervention in public health. And in fact, what we saw from Derry was even communities with a very basic and rudimentary introduction to the wider issues of public health had found it much easier to embrace specific lifestyle change programmes in areas such as alcohol, obesity, smoking and diet and nutrition. And what we also saw is that the Derry model showed how lifestyle was very much determined by a range of social, economic, physical and cultural environments. And for us it was very important to recognise how we could adapt that as we took forward our work in relation to alcohol-related harm in the North West. We saw that economic disadvantage and social exclusion were particularly key to understanding how population health was developed, and we learned that all of the factors that lead to poor health inequality needed a strong interagency approach to making sure that the change could be taken forward. So as we did our work to mobilise communities, we adopted an approach that picked up the best of learning that we could from Derry and from other parts of WHO area as well. Firstly, we recognised that those most at risk of ill health are those who are most likely to be marginalised or excluded from public consultation processes. Secondly, they are also the most likely audience to find it very hard to express their views in terms of what their needs are and what the pressures are that make them make the lifestyle choices that they do. We have sought, therefore, to make social inclusion very much at the centre of our processes on lifestyle change, whether that be working with ethnic minority groups, working with mothers, working with people who found themselves in some other form of disadvantage. It's critical that we work with them at centre at all times so that they can work with us in progressing the change that we see needs to happen. We've recognised as well that the health inequalities are determined for a wide number of factors. And for that very reason, we recognise that there are many stakeholders who have a role to play in changing public health and changing lifestyle behaviour. Unfortunately, not all of those stakeholders sometimes recognise the role that they have to play. So as we have developed our work in the Alcohol Forum, taking our learning from Derry Healthy Cities, we have done an awful lot of work to build the intelligence base within our key stakeholders so that they see a role for themselves in changing that public health behaviour. And we have helped our stakeholders, I suppose, become more aware of the fact that they do have, it may not be a core agenda item, they do have an impact on the health of the population. Finally, we recognise that the focus of health improvement and changing lifestyles has to be very much on the health of a population as opposed to the sickness of particular individuals. For us to change alcohol culture in the Alcohol Forum, we recognise there is more to be achieved in changing the behaviour of society in relation to alcohol than those who have the most chronic alcohol-related problems or addictions. And in taking our learning from Derry as well and in building that into a North West regional concept, we've been very clear that central to changing lifestyle choices is the development of capacities in communities to improve their social capital. What we have been doing through the Alcohol Forum is providing very basic at times information and education through a tailored package of training, of skills-based development to enable communities to fully understand the impact of their lifestyle choices on their community, and that in turn builds their social capital to effect change in their community. We have also built upon the settings approach as a way of influencing the way in which people think about their lifestyle issues and changes. We currently work in social clubs, in community groups, we work with families, we even work in emergency departments using those key settings as a way to speak directly to the public at a time when they're most attuned to the message that we're trying to give to them, to allow them to start to learn and build their own understanding of the real challenges around lifestyle change. And I suppose one thing that we have harnessed a lot of energy into in taking forward our learning from what's happened in Northern Ireland is the idea that civic leadership is a key mechanism that enables stakeholder engagement and offers that broad strategic connection with all stakeholders in the community that allow change to happen. For us working with councils in the northwest of the country, we've been able to influence the agendas of sports partnerships, of county development boards, community partnerships and town councils. By offering that level of, I suppose, remit for health within a council, which isn't something that councils in Ireland very strongly have to the fore, we've also seen how that then enables other natural leaders in the community, whether that be TDs, senators, sports coaches, community workers, take a lead in changing how that lifestyle change can be affected through behaviour change. Through our strategic partnership with Derry Healthy Cities, we're very clear that the sharing of learning between both organisations has enabled us to start to make a difference in the lifestyle choices and community health in the northwest of the country. And whilst we recognise that there are healthy cities, and it should be said there are healthy cities approaches elsewhere on the island of Ireland, most notably Galway and Cork, they do have a real opportunity to provide a mechanism for the imminent public health strategy to start to influence the way in which communities react to health and well-being, albeit they will be predominantly focused in an urban context. What we would like this committee to think about is the mechanism and the culture and the process that has been developed in the northwest of Ireland today. By developing our work on a cross-border basis, we've seen how the progression of a public health strategy in the Republic of Ireland will certainly help us make dramatic change on how we improve lifestyles for our communities. However, we're very keen that we don't lose the idea that Northern Ireland has had a public health strategy for over 10 years already. They have learned significant amounts and they have made some mistakes as well. What we would be very keen that this committee think about is how we utilise that learning as we take forward public health and lifestyle change in the Republic of Ireland. The Alcohol Forum has already started that mechanism, has already created a communication route through which that can happen. And we hope that as the public health strategy in the Republic of Ireland comes on stream, that we can provide a key vehicle to allow the country to learn more about health improvement and learn more about how the mechanisms used elsewhere can help communities change.
Conclude, please.
And I could just say that we can provide much more information, obviously, in due course on how those mechanisms work, but I'd like to thank the committee today for their time. Thank you very much.
Thank you very much. We have now some people indicating to ask questions, and our time is somewhat constrained, but I'll try and accommodate everybody. The first person here is Senator Colin Burke and then Ronan Mullen.
Thank you very much, Chairperson. Just a very brief question. It's in relation to graphic images on cigarette packs. We haven't really made a huge, there hasn't been huge progress made in relation to getting a substantial reduction in the number of people smoking in this country. I know there's been some slight reduction, but it hasn't been substantial. Where graphic images have been used in other countries, has it had that effect of getting the reduction that we really want to try and target? I mean, in fact, I understand, I haven't looked at the figures recently, but the last lot of figures I looked at, especially young women, there were more young women now gone back, or certainly there has been no impact on that group as regards reducing the number of them that are smoking. So I'm just wondering, the use of graphic images on packages, will it have the effect that the target would be set?
You're absolutely right that there's a very high proportion of young women still smoking in Ireland. There has been, through increasing tobacco prices and workplace ban and other restrictions over the last 10 or 12 years, a 22% reduction in smoking prevalence in this country, but it remains too high at over 25%, 29% in the young women category that you speak of. With regard to to graphic images and so forth, we have small health warnings on cigarette packs that appear to go unnoticed, and most smokers would say that. In places, in jurisdictions particularly, and places that are ahead on this, or particularly we look to Australia, there has been a reduction. So if we say a 25% smoking prevalence rate, in Australia they're at 15%. They have graphic images on their cigarette packs. I mentioned the plain packaging, which includes both graphic and no other advertising on the packaging. And that seems to be certainly in studies of sort of market research and so forth, seems to be, I mentioned there, associated with a reduction in desirability of a product that really advertises and sells itself through the medium of the packets. Using colours, for instance, light cigarettes, mild cigarettes, and all of these misconceptions, and they're in particular a concern with regards to plain packaging and so forth, that those claims cannot be made on a plain packaging cigarette packet.
Senator Mullen.
Can I just thank our guests for their presentations? If I might just address a question to Ash Ireland. I found your 5 recommendations very interesting and somewhat challenging as well. My cousin here in front of me will know what I mean when I say that I've often thought that one of the joys of growing up was being brought to matches and getting the smell of some of the sweeter tobacco being smoked in older men's pipes around the pitch. So I may have to be re-educated on that particular one, because I was thinking of trying to make that a protected cultural activity. But if I could ask you, maybe more seriously, taking those 5 recommendations together, What would you say, practically speaking, would be the effect if those 5 proposals around banning smoking in education campuses and sports stadia and the plain packaging and the smoking ban in cars? You've put a figure on the cost of smoking-related healthcare, 1.5 billion. It's very stark. But have you done, or is there any way of doing costings on where we would be at if we were to bring those 5 proposals into effect?
Well, I think the measure of these things is prevalence and mortality associated with smoking-related diseases. And I feel, ASH feel, and I think the vast majority of medical science and support would suggest that these types of measures are what reduce prevalence and reduce smoking, denormalize cigarette smoking, make it less desirable for people who start, which are children. Right? 16, 17, 18-year-olds are the people who start smoking in this country. Very few people start smoking at the age of 40. But what we can do with these types of initiatives is set ourselves up as the leaders in this area. Where we did 10 years ago with smoking ban in workplace, we can do so in these areas which are both associated with public health benefits and the other benefits that I mentioned. And ultimately, we would be measured on the prevalence and, more importantly, a reduction in smoking-associated conditions. My colleague, Dr. Brown, might want to come in.
Just to add to that, really, as Dr. Moran says, this is a part of the denormalisation process. We need to deglamorise cigarettes for young people. We need to stop young people starting, because once they start, this is a highly addictive product that is extremely difficult to give up. This process that we've talked about today is only part of the process, though of course we need to continue to increase price of cigarettes, because that's probably the single most important thing that does stop young people starting the price, and obviously then clamp down on smuggling. So this is part of the process that Ash Ireland is particularly calling for, this denormalisation process, removing the product, deglamorising it.
Senator O'Keane and Senator Healy-Eames, and I'll let the two of you ask questions and we can bank them. And,
yeah. Thank you again for your presentations. Mr. O'Kane, if I could just ask you to clarify a point that you raised in relation to being in emergency departments and talking to people when they are most in tune with what we're saying. I think that's a very interesting concept, because of course part of the problem is that people are not ever in tune with whatever everybody's saying. So maybe you might clarify or give us a very fine example of what you mean by people being in tune, and is there some way in which we could expand that idea for all the other messages that we're trying to get across? And if I could also ask Dr. Morgan, I think you said that you had approached the GAA and the IRFU and others. I'm not sure if you said what their response was. Perhaps you don't know yet, or perhaps you're not in a position to say, or perhaps I wasn't listening. Thank you.
Senator Healy-Eames, if we'll let you in as well. And
thank you very much.
Brief questions.
I won't say Mr. Ash, but I can't see your name from here.
Dr. Morgan.
Dr. Ross.
Yes.
Okay, thank you for your presentation. I'm aware we have a number of health promoting colleges in the country, third level colleges, and I just wondered, given the enthusiasm that you expressed for those colleges, I like your ideas about them being highly restrictive smoke-free places, if not completely restrictive. Do you think legislation is necessary to achieve that? That's the first part of it. And with regard to plain packaging, did you say it's Australia that it's working, and what has been the reduction? Remind me again, plain packaging versus so-called normal packaging. And final question to Mr. O'Kane. You came out with a very important statement, in my view, that health is too important for the health system alone. I always remember Dr. Pat Durley saying that when he was head of population health. He used to say it was better to invest in education, to educate for health. Now, we don't have that ethos at all in this country, because we're always on about the curative model and the treatment model, because by the time we have a problem, it's too late to prevent it. What evidence is there that, have you got evidence, new figures to show an investment in education and in health promotion gives better return for your buck, if you like, than in the curative, than waiting for it to be too late?
Could you respond to that now? And,
go first in relation
just remind you again that we were
to the two questions. Firstly, Senator, in relation to the emergency department approach, some years ago the Alcohol Forum was involved in a piece of research that looked at the cost of alcohol to Letterkenny General Hospital, and at that time it was estimated to be anywhere between 20 and 40 million euro per year in terms of the impact of alcohol coming through. What we then did is we built a relationship with a piece of research coming out of Trinity College to look at the idea of early intervention and brief intervention in relation to alcohol harm in the emergency department. On a Friday, Saturday night on Letterkenny General Hospital, 3 in every 4 admissions were alcohol related, and it seemed an obvious place to start to talk to people about their risk-taking alcohol behaviour. As a result, we've continued to work on that model. The SEER model that has been developed now is being rolled out across the country, and I believe Trinity have been influencing that process as it moves forward with the HSE. In relation to the question about models of how public health intervention makes a difference through a health promotion approach, I suppose our near neighbours in Sweden are probably the best examples of where they took a very early idea of getting upstream, trying to prevent ill health as opposed to dealing with the health when it became a sickness problem in hospitals. There would be quite extensive WHO evidence to show how that health promotion model is most effective. I think historically and culturally as a country we've tended to think about illness as opposed to health. And I think what we're trying to foster through our piece of work and hopefully through the public health strategy will be the idea that prevention is better than cure. Okay,
thank you. Senator, do you want to respond?
If I may respond, to those few points. Thank you. With regard to the third level institutions and the enthusiasm that they've displayed thus far, I think that certainly